This is Dr. Mansoor Madani, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, and Associate Professor of Oral and Maxillofacial Surgery at Temple University Hospital, Philadelphia, Pennsylvania. The topic of today's presentation is adult and pediatric medical emergencies. Prevention, preparation, recognition, and management will be discussed. My goal in creating this presentation is to provide continuing education courses that are relevant, highly educational, useful in daily practice, up-to-date, required by law in some instances, and applicable to all dental as well as medical professionals. My goals are to promote and encourage lifelong education for the dental and medical professional and their team by presenting well-researched programs in a unique online setting. Also to share information on advancing technology and procedures, diagnosis and management of various subjects of importance for practical application by any practitioner as well as their auxiliary staff. Additionally, my hope is to encourage and assist all my listeners to achieve higher level of skill, knowledge, and competence. But most importantly, to provide continuing education program that enables practitioner to provide the highest level of care to their patient and their community. With that in mind, let's begin the first part of multi-segment presentation on one of the most important subjects in medicine, which is medical emergencies. Medical emergencies in medical and dental practices, although rare but are not uncommon. Before I start this segment of presentation, let me stress that when and if you are well prepared for emergencies, the emergencies somehow cease to exist. Let me repeat this line again. If you are prepared to deal with any emergency, if one happened, you and your staff will not even think of it as a big issue and will handle it calmly, professionally, and safely. Every time I give this lecture, there are few common misconceptions about emergencies that I hear from few of my audience. One practitioner told me that emergencies don't happen in my office at all. Another practitioner told me that I have been practicing for 28 years and not a single emergency happened. Then he continued to say that, well, I had few people passed out during those many years in practice. He added, anyway, if there was an emergency, I just call 911 and they come and take care of it. I don't need to know too much about the emergencies. During my presentation, I advise everyone during an emergency to stay calm, be prepared, and make sure your team are well trained too. And one of my colleagues told me that in my office, nobody panics. My answer was, I hope that is true, because if we connect a monitor to any practitioner, their blood pressure and heart rate most certainly goes up during an emergency. But how we react or appear may be different. Think of it. If you ever had any medical emergency in your practice, well, you don't have to raise your hand as you're watching this video, but think of it. It is imperative for any professional health practitioner as well as their entire team to be familiar with the prevention, diagnosis, and management of common emergencies. Let's first look at the frequency of medical emergencies. In 2019, there were over 200,000 dentists in the United States and around 1 million physicians practicing in tens of thousands of practices. American Dental Association says that there were 61.1 dentists working in dentistry for every 100,000 US population. 33.4% were female, and of all of those dentists, 21% were specialists. Now let's look at the frequency of medical emergencies in a dental practice alone. Based on ADA report, 7.5 emergencies occur for 10 years in practice. Historically, 10 to 12 patients die from emergencies in dental practices per year in the United States. Approximately 20 to 30 deaths of pediatric patients since 2007. Of those over 200,000 dentists, they reported 150,000 emergencies in dental practices each year. Of course, if you were lucky and did not have any emergencies in 28 years of practice, you were either exceptional or possibly did not consider those problems as emergencies. Here's an example of a sad story of a toddler who passed away. The alarm of the anesthesia unit in a pedodontic office was annoying, so they turned it off. They failed to also check the oxygen tank to make sure that it's full of oxygen. A question that I always ask is, what if you, the doctor, had a medical emergency? Are your team ready to take care of you? Or if you had two simultaneous emergencies occurred in your office, do you have any plan? Remember, disasters and unfortunate emergencies happen even to a totally healthy patient, like this young, healthy patient that presented for removal of her wisdom teeth. Based on a report in USA Today in 2017, Miss Gallagher was having her wisdom teeth removed. When her blood pressure significantly increased, her pulse dropped, she went into cardiac arrest. She later died at the hospital. But who was at fault? You would think that only the dentist was at fault. But in that case, the entire staff were named as negligent, not trained, and not prepared in the lawsuit. So, could this have been prevented? In this case, I really don't know, but the answer is maybe. Was there a thorough medical history taken to ask the patient about any underlying cardiac or pulmonary issues, liver or kidney diseases, any blood disorder, as well as any other medical condition, including rare conditions or diseases, to name a few? Don't forget to ask about their social history, about any substance abuse history, any previous surgeries or anesthesia, or problems in the dental office or during past hospitalization. Now think of it. When was the last time you had a staff training in your office? Do they all have CPR certificates? Does everyone in your office knows the location of AED and emergency drugs? The bottom line, to avoid mishaps and to manage an emergencies in any practice, everyone must be vigilant and work as a team. We have to differentiate negligence versus emergencies. In February of 2020, a New Jersey dentist's license was suspended after a deadly bacterial outbreak left one person dead and 12 needing surgeries. It was reported that many of these patients developed bacterial endocarditis and required aggressive treatments. That alleged negligence included a failure to use sterile water or saline during the surgical procedure, improper handling and storage of single-dose medication vials, non-sterile preparation of instrument, improper handling and disposal of needles and syringes. The simple question here is, could this have been prevented in this case? This was not emergency. They were considered that as negligence. Why are we here? Why are you listening to this presentation? The fact is that medical emergencies can and do happen. Today's medical and dental practitioners encounter a complex patient population, aging, comorbidities, multiple medications, new generation of medication, and advances in evidence-based practices. New terminology provide expansive and ever-changing best practice guidelines for every level of patient care. On top of that, more and more complex dental procedures are done, in some cases requiring longer appointment time, which puts particularly elderly patient at higher risk of complication. Here's an example of a patient that I saw and requested clarity on her medical issues from her MD. I received a letter of clearance back from her MD stating that the patient has the following issues. Unfortunately, not in good handwriting, so I deciphered and typed it up for you. He wrote, patient has AVR, MVR, PACE, 1 BP, possibly an arrow, upward arrow, means increased blood pressure, CHF, DM. I'll explore these abbreviation terms later. But he wrote, don't stop the blood thinner, otherwise she is cleared to be treated for dental extraction. Just give antibiotic prophylaxis. Complications and emergencies happen when we don't know about the patient's illnesses, not asking the patients and not researching that illness or device that they may be wearing, or patients not telling us about their illnesses. Well, I had a great patient that brought his list of medical problem and medication with him when I asked him, what kind of medical problem do you have? His list was much more in detail, but some of his conditions needed exploring more. So he said, I have PAD, CAT, cabbage, SCAD, GERD, TIA, HTN, DM, Hep C, and Hep B. Thrombocytopenia did. Oh, by the way, I have an implantable pacemaker too, he added. So what do those abbreviations mean? This abbreviation stands for PAD is peripheral arterial disease, CAD is coronary artery disease, cabbage is coronary artery bypass graft, SCAD is spontaneous coronary artery dissection, GERD is gastroesophageal reflux disorders, TIA is transient ischemic attack or stroke, HTN is for hypertension, DM is for diabetic mellitus, Hep C and Hep B is obvious for hepatitis, thrombocytopenia, DID is dissociation identity disorder. The next question is, what medication do you take? If patient does not have a copy of her prescription, use the RX program from any pharmacy to get the detailed prescription list. And here's this patient's list. She said she takes Victoza for diabetes, Pradaxa, which is a blood thinner, Gentoven, which is warfarin, atorvastatin. Most of our patients are taking a statin drug for cholesterol, Pletol, which is antiplatelet, Norvasc for hypertension, Lisinopril, which is an ACE inhibitor for blood pressure, nitroglycerin, Prilosec and Nexium for esophageal reflux or GERD, aspirin and Plavix, both of them. This patient is taking 3 different blood thinners, Pradaxa, aspirin, and Plavix. So the bottom line is to look at the list of medications, know them, and know what drug interaction could be expected, what precaution you have to take to avoid complication or even unforeseen complications. Here is a true story. It was a Friday afternoon at 4 p.m. A dentist pulled 5 teeth 1 week earlier. Now patient is back. And she said, I'm here for the other 5 teeth. The dentist forgot her medical history, but remembered the patient. According to the report, patient collapsed shortly after the second of the 2 appointments scheduled within a week of each other to extract 5 of her upper teeth to replace them with denture. Patient was then taken to a hospital emergency room. In the hospital, the patient was admitted with severe bleeding, treated with gauze, applying pressure and local anesthetic, advised not to rinse her mouth for 24 hours, discharged from the emergency room, but bleeding resumed the following day. She collapsed for a second time. However, unfortunately, a few days later, patient died. This could have been prevented if proper steps were taken. We will discuss it later. And of course, the news was that patient bled to death when she had 5 teeth removed by her dentist. You most certainly do not want to be in the news for such preventable situation. New medications, diagnosis and technology. Honestly, it is hard to keep up with them. You should know more than your patients or just learn from them. Will you be surprised to hear a patient telling you that they have artificial pancreas or internal defibrillator or pacemaker, or they use auto-rapid HIV testing or rapid COVID testing at home? How about vein finder sheet? How about a handheld pocket CPR in case they needed to do that to their family members? One of the greatest and rapidly more and more popular is the new diabetic glucose level testing. Checking glucose with a painless scan instead of a finger stick, using the Freestyle Libre as an example. This is a great time to mention that it should be your standard practice to test diabetic patient for the blood glucose level prior to your dental procedure. If any patient have the Freestyle Libre, they can simply touch their phone to the attachment on their body, usually is their arm, and instantly you will see their glucose level. This is just one of those devices that you may never heard of it. I recently had a patient that came to my office for oral surgical procedure. She said, I have Watchman. I was surprised. I said, oh, yes, I watched the Watchman HBO series too. She said, no, I'm not talking about a movie. I have atrial fibrillation and I have a Watchman device. Since many dental professionals may have not heard of this device, let's first explore atrial fibrillation. Atrial fibrillation, or AFib, is one of the most common type of cardiac arrhythmia. Heart beats much faster than normal. Basically, in simple language, the atrium and the ventricle of the heart do not work in synchrony. The ventricles then don't fill completely and pump enough blood to the lung and the rest of the body. Patients may be asymptomatic or feel tired, dizzy, with heart palpitation or chest pain. Patients have a very high risk of blood clot formation in the left atrium, leading to heart attack and a stroke. If you look at the left atrium on the heart, there is an extension or an appendage that, when the heart beats too fast, is a perfect site for blood clot formation. In patients with AFib, as the blood circulates here, it can coagulate and create blood clot. So normally patients are placed on Coumadin or other blood thinners for the rest of their life. Watchman is an alternative to lifelong use of warfarin for people with AFib not caused by a heart valve problem, also known as a non-valvular AFib. It blocks the entrance of the blood to this left ventricular appendages, and therefore there is no need for blood thinner. Now that we know about this device, what is it about this device that as a dental professional we have to know about it? Do they need antibiotic prophylaxis? Yes. 6 months following the device implantation, we need to prophylax the patient prior to certain procedures. The company says the decision to continue endocarditis prophylaxis beyond 6 months is at the physician's discretion. Since I mentioned blood clot and anticoagulant, remember that FDA warns interaction between Plavix, which is a blood thinner, and Nexium, Prilosec, Prozac, and Tagomet, Diflucan, Ketoconazole. They all reduce the effectiveness of Plavix. Speaking about medical emergencies, if they are managed properly, most emergencies are resolved satisfactorily. Mismanaged, even benign emergencies can turn disastrous. Our goal is to be ready and prepared to prevent it from happening, diagnosing the urgent situation in a timely fashion, recognizing the situation as soon as possible, place the patient in a correct and comfortable position, stabilize the patient, then treat the patient appropriately, refer or transfer the patient if needed to an emergency room. Doing all that while confident, thoughtful, but hopefully surrounded with a great team of staff that are well trained to respond to an emergency. Our medical doctors, they say we don't create any anxiety or fear, but as dental professionals, what do we do that can affect the physical and emotional health and well-being of our patients? Well, we instill fear, anxiety for some patients. We inflict pain, injecting local anesthetic solution, injecting potent vasoconstrictor, prescribe powerful medication that may include central nervous system stimulation and depression, respiratory and circulatory disturbances, as well as allergic reaction that could be created from those drugs. Our procedure may lead to extensive bleeding. We can cause gag reflex by simply placing an instrument in the patient's mouth, dictate body position in the dental chair, expose the patient to radiation, expose them to dental material, or inadequately protecting the airway, causing aspiration of foreign object. Look at these next few pictures. This is a 3D CAT scan of a patient that I saw in the emergency room after aspiration of a tooth. Aspiration of multiple teeth fragments in the lung and the pharynx is clearly visible in these 3D CT pictures. Remember, 4 basic steps are required to handle an emergency: preparation and ongoing training using shared knowledge, prevention, response, and management. First step is preparation. Preparing for a medical emergency in a dental office requires organization, preparation, and continued training and review for all office staff. Making sure that practitioners and the entire team are well trained. I recommend every 6 months. You can do it every 3 months. In my own practice, we do it more often because when my staff are trained and ready, when an emergency happens, they are sharp, ready, and confident to help. Next thing is CPR training for the entire team. In periodontic offices, as well as oral and maxillofacial practices, pediatric advanced life support, or PALS, and ACLS are required for all practitioners. Although keeping the appropriate emergency equipment and drug on hand is important, the training and expertise of the dental team in BCLS as well as ACLS and PALS makes all the difference when responding to a medical emergency. Knowing how to use AED for the entire staff should be mandatory. Emergency drill, as I mentioned above, should be routine practice. A general recommendation is to conduct emergency drill quarterly. Knowing emergency numbers to contact EMS and even local emergency rooms are essential. Having crash cart and emergency equipment are basic requirement. Oxygen tank and oxygen delivery system should be checked regularly. Other respiratory system and support equipment should be present in good working order and located according to the emergency plan. I will address what is needed as far as the emergency medication in a general dental practice in the next few sections. But I stress here that all emergency medication should be checked and replaced, and they should be ordered for a specific drug before their expiration date. In this picture, you can see a portable suction system that is very useful in case of electrical outage. In my opinion, continuing education courses on medical emergency must be mandated at least every 2 years for license renewal, as is in the case of in some states and some countries. Actually, they do require that should be repeated every 2 years. Here's what I recommend as emergency action plan. Conducting mock emergencies may help office staff to be more confident with their role when a real emergency occurs. As a result, medical doctor and dentists and their staff should be prepared to recognize, respond, and effectively manage a medical emergency. First, all employees should know their role in an actual emergency. For example, who is responsible to call 911 or emergency response team. Emergency phone numbers should be placed prominently near each phone. Even better idea is to have all staff put the local emergency number in their mobile phone. Who's responsible to take care of the patient? Who's responsible for documentation? Is there a contingency plan should a staff member be absent? Who is the staff assisting patient's family? Who is assisting the other patients in the waiting room? And who is responsible to direct EMS to the location? Now let's talk about emergency equipment. A portable e-oxygen cylinder with a regulator is what is recommended. E-cylinder that holds more than 600 liters, yet is easily transportable. This unit, as shown on the right side, costs about $400 and is one of the most important equipment you may have in your practice. Oxygen source and flow meter, nasal cannula, non-rebreathing mask with oxygen reservoir. Every office must be able to deliver oxygen under positive pressure for the unconscious or apneic patient. The most effective method is a bag valve mask device connected to an oxygen source. I use demand resuscitation valve, which is my favorite device. One of the best and most effective way to deliver positive pressure oxygen to an apneic patient is the demand resuscitation valve, and it costs about $300 to $400. With the push of the button on the back of the mask, it can deliver 10 to 15 liters per minute of oxygen. Just make sure to push the button on and off about 12 to 15 times per minute. Other equipment recommended are oropharyngeal airway, McGill forceps, which helps with intubation of the patient and also helps with removal of any foreign body in the back of the patient's throat. Suction devices, powered and manual backup. These are some really good equipment to have. Also, of course, if in an oral surgery practice, we have laryngoscope, a handle and blade with batteries, extra batteries as well. Any medical or dental office should be equipped with an emergency equipment, and the supplies should be appropriate for that office. Should you make your own sets or purchase a pre-made kit, that's a decision that you make. Once you complete this course, please call my office to receive a laminated, comprehensive list of all medication and most common emergency situation. Our direct phone number is 610-667-4455. If you're listening to this video from other states or countries, we can email you a copy of that form. The next step after preparation is the prevention. This is the most important and easiest aspect of preventing medical emergencies. Be prepared to deal with the likely cause of the emergency. May take extra time, but in the long run, it will save you from stress and headache. It is estimated that approximately 90% of medical emergencies can be prevented by following a few simple rules and procedures. So what are those simple rules and procedures? First, and most importantly, obtain thorough and updated medical history. Contact MD for medically complex patients, or if you suspect any undiagnosed condition, for guidance and more detailed information. Perform the most basic monitoring of the vital sign every time, including taking blood pressure and heart rate. You may want to take the patient's temperature as well. If indicated, blood glucose level. In most cases, diabetic patient can bring their own glucometer and do it in front of you, or if they have any other devices, they can also bring those and show it to you. But remember, the most important strategy is never treat a stranger that you don't know their medical history. By checking the accuracy of their medical history, they would not be a stranger for you. Next step after preparation and prevention is the recognition of the problem. Recognize patient's anxiety, recognize early sign of an emergency, modify your medical or dental treatment, anticipate and be prepared to manage emergencies, and importantly, stay calm and don't panic. Patients' anxiety and stress are considered a major contributing factor in medical emergencies. Hyperventilation, syncope, seizure, anxiety-induced hypertension, heart palpitation, heart attack, asthmatic attack, to name just a few. So few strategies for stress reduction. Before you start any treatment, obtain detailed medical history, not only written, verbal as well, to reinforce that history that patient gave you. Good communication, show empathy, recognize patient's apprehension. Schedule apprehensive patients early in the day and make their appointment as short as possible. Premedicate the patient if they need that. Review informed consent form. During the procedure or during the treatment, talk to patient if awake. Topical anesthesia followed by local anesthesia, and be patient after you give local anesthesia. Ensure profound local anesthetic. Use local anesthetic agent containing a vasoconstrictor congruent with the patient's functional capacity. Remember, avoid mepivocaine or marcaine for very young children due to prolonged anesthetic effect that they can bite their tongue or their lip, so you should avoid that. Offer nitrous oxide or IV sedation if you are able to provide IV sedation. After the treatment, written and verbal instruction, proper pain management, follow-up call, document, and refer to a specialist if needed. Determination of medical risk. Know ASA. What is ASA? It stands for many things like aspirin, American Society of Aging, American Soybean Association, and many more. But the one that we are looking for stands for American Society of Anesthesiologists. Interestingly, so that you don't get bored, few may realize that the ASA physical classification system evolved from the field of dentistry. The first proposed classification system was offered in the 1940s by a dentist turned anesthesiologist, Dr. Lenny Monahan. He offered the basic ABC classification. During the same decade, an oral surgeon, Dr. Harry Archer, developed a second patient classification system. Dr. Archer's classification proposed a 1, 2, 3 patient classification system, which provided the foundation for the dental patient risk evaluation. In 1963, the American Society of Anesthesiologists published its first version of the patient physical classification system. The classification system was developed to assess patients' risk for patients undergoing sedation and anesthesia. The original publication consisted of only 5 categories. Then a 6th category was added later. American Dental Association guideline recommend that all dental professionals must have a clear understanding of ASA in order to safely select patients for the appropriate level of dental practice. With that in mind, I like to review the ASA physical status guideline and their application to dentistry as well as medicine. So let's look at ASA 1. ASA 1 is a patient without any systemic disorder, a normal healthy patient, fit, non-obese with BMI under 30, a non-smoking patient with a good exercise tolerance. And as far as dental management, they can tolerate the stress involved in dental treatment, no added risk of serious complication, treatment modification usually is not necessary. How about ASA 2? ASA 2 is a patient with mild systemic disease with no functional limitation, well-controlled diabetes or hypertension, blood pressure of 140 to 149 over 90 to 94, well-controlled epilepsy, well-controlled asthma. ASA 1 with anxiety and extreme fear of dentistry, older than 60 years of age, pregnant, mild obesity, and smokers are amongst ASA 2. As far as dental management of ASA 2 classification, represent minimal risk during dental treatment. Consider minor modification, short, early appointment, and if needed, provide sedation. ASA 3 classification includes a patient with severe systemic disease that limits activity but is not incapacitating and is not life-threatening. A stable angina, 6 months post a stable MI or a stable stroke. Severe asthma, COPD, poorly treated hypertension with blood pressure between 160 to 199 over 95 to 114. Hypo or hyperthyroidism when they have symptomatic. Morbid obesity, poorly controlled diabetes, alcohol dependence or obese. Implantable pacemaker, patients that they have moderate reduction of ejection fraction, and we're going to talk about that. End-stage renal disease undergoing dialysis. A bronchospastic disease with intermittent exacerbation. How about the dental management of ASA 3 classification? Consult MD first. Blood pressure must be under control. Dental treatment, consider risk versus benefit. Treatment modification is required. Reduce stress and pain. Consider IV sedation if possible, or nitrous oxide. Make the appointment very short and early. ASA 4 gets a red flag. A patient with incapacitating systemic disease that is constant threat to life. Patient with functional limitation from severe life-threatening disease. Multiple combined uncontrolled diseases, for example, diabetes, MI, congestive heart failure, COPD, and a stroke. Myocardial infarction or recent heart attack, whether it's MI or a stroke within the last 6 months. Remember, if emergency dental treatment is needed, medical consultation is required first, and it is preferred that these patients are treated in a hospital setting. Blood pressure greater than 200 over 115 and is uncontrolled hypertension. There are other patients that they are classified under ASA 4. Cancer patients currently treated with chemotherapy, unstable angina, sepsis, disseminated intravascular coagulation or DIC, uncontrolled epilepsy or seizure, renal failure with refractory ascites and end-stage renal disease not undergoing regularly scheduled dialysis. As far as dental management of ASA 4, remember the red flag. Consult with MD first. Postpone elective dental procedure until condition has improved to at least an ASA 3 classification. Perform emergency dental treatment only. Treat only to control pain and infection. Other treatment should be done in a hospital setting, such as extraction of teeth or incision and drainage. There are really some good general rules to get medical consult. If you have a patient that has unstable angina, heart failure, significant arrhythmia, valvular heart disease, high blood pressure of over 160 over 90, low blood pressure of less than 90 to 60 with symptoms, or if a patient has MI, a stroke within the past 6 months, has CABG or coronary artery bypass grafting within past 6 months, cardiac stent that was placed within the past 6 months, or as a pacemaker or automated implantable cardioverter defibrillator or AICD, they need to be consulted with, you need to get a medical consult from the medical doctor. Or if they have bacterial endocarditis also, they would be, it's a good rule to get medical consult. The next ASA classification is 5, also red flag, maybe double red flag. A morbid patient not expected to survive with or without an operation. The patient is not expected to survive beyond the next 24 hours without surgery. End-stage renal, hepatic, and infectious diseases. Ruptured abdominal or thoracic aneurysm. Extensive intracranial hemorrhage with mass effect, and terminal cancer. Dental treatment of ASA 5, elective treatment is definitely contraindicated. Emergency care only to relieve pain in a hospital setting. And ASA 6 is recently added class, clinically brain dead being maintained for harvesting of an organ. Please get an updated medical history on every visit because ASA status can change as the medical history changes. So it is important to update before all dental procedure. Get a written update as well as verbal update. You would see some cases that I'm going to present that the patient was seen earlier, but within 6 months, patient's medical condition has significantly changed and put some dental practitioner in trouble. During these presentations that I have prepared, real-life scenarios are presented in this series of presentations to create an environment in which any practitioner could face and must practice intelligently and defensively. The ability to conduct an accurate patient risk evaluation becomes the basic for informed practice, patient selection, and risk mitigation. Too often we give answer for our audience to remember rather than problem to solve. So I present a case and ask you to try to come up with a diagnosis. So let's begin our case presentation and see how you like them. My first patient is an actual case that I treated after his encounters and injuries. 89-year-old patient presented to his dentist late Friday afternoon for a partial denture insertion. Office staff were gone and the doctor was by himself. The impressions were taken over 8 months ago. But patient just showed up and the doctor found his already made dentures and was ready to insert in his mouth. He has a folder of papers, none of which were his health history or medication list. While sitting in the dental chair, he made a soft groaning noise, complained of chest pain, and then started losing consciousness. What happened? What do you do now? You are confident that you have everything that you need. Oxygen, nitrogen, epinephrine, AED, and so on. So the first thing you check is your AED unit. You look at the AED, however, there is no light indicator. Possibly the battery is expired or does not have any charge, is not charged. The pads are also expired. As many of you guys may not even know that these pads, they do expire. So you have to check the AED pads all the time. Next thing is you have an emergency crash cart. So your emergency box or crash cart has many things, but few items are missing. Few drugs in it are expired. You turn the oxygen canister on and it is empty. Who do you blame? Did you have someone in charge of checking your emergency medication expiration date and replacement of used or missing drugs? How often you check the AED pad and battery for expiration date and replacement? Think about it. While you're thinking and writing notes to yourselves, let's keep your thinking caps on as we explore several issues. According to the CDC, the top 10 leading causes of death in the United States in 2019 were as follows. Heart disease was number 1, followed by cancer and accidental or unintentional injuries. About 170,000 people died from accidental injury. Chronic lower respiratory disease were the 4th. Stroke was the 5th. Alzheimer's disease, diabetes, influenza, and pneumonia, with about 55,000 people dying in 2019. Kidney disease and intentional self-harm or suicide was about 47,000 people dead because of that. My prediction for 2020 would be that the third leading cause of death in US will be COVID-19. Listen to my initial lecture that was recorded early in March 2020. Since that time, over 1 million people have died internationally, over 40 million people infected. Interestingly, about 30 million people have recovered from that infection. And we talk about that at a later time. But that number of where's the ranking of diseases will change in 2020. When we look at unintentional injury, here are a few cases. A 4-year-old child died in a pediatric dental office where he was given combination of Demerol, Valium, hydroxyzine, and nitrous oxide to place several stainless steel crown. In 2016, a 6-year-old boy died getting tooth extracted. He stopped breathing while under anesthesia. Oxygen desaturated, but was not noticed and led to cardiac arrest. These unfortunate accidents are very rare, but an article which was published by Johns Hopkins in May of 2016 stated incorrectly that, quote, more than 250,000 people in the United States die every year from medical errors. Based on several papers published since that article, the above estimate was inaccurate, but it is being used by lawyers and patient safety advocates to take legal action against doctors. Every human loss is a disaster, but what else could be categorized as unintentional injury? Well, car accidents are unintentional, and a lot more people die of car crashes than medical error every year. Now let's look at some important facts. Every 20 seconds, someone has a heart attack. Every 1.2 minutes, someone dies of a sudden cardiac arrest. Every 45 seconds, someone has a stroke. Every 3.3 minutes, someone dies from a stroke. Every 3 minutes, someone has a seizure for the first time. And every 6.6 minutes, someone has an anaphylactic reaction. When a patient has developed a stroke, how fast patient is sent to the hospital, how fast the issue is addressed dictates less chance of brain damage and recovery. Finally, we have to talk about the most common medical emergencies in dental practice. And what are they? Syncope, of course, is number one. Mild allergic reaction, anaphylaxis, epinephrine reaction with heart palpitation, hyperventilation, acute asthma, asthmatic attack, postural hypotension, hypoglycemia, insulin shock, seizure, angina, myocardial infarction, cardiac arrest, stroke, and foreign body aspiration causing obstruction of the respiratory system. Many of these events are preventable, or at least the chance of them occurring can be lessened if you are prepared, practiced, and have a plan of action. When we talk about managing medical emergency, a common sense and basic concept is in 5 words, and that's a sport. What does a sport stand for? First, S for stop the procedure. That is common sense. When something happens, an emergency occurs, you have to stop the procedure. Position the patient, starting with P. Deliver oxygen to the patient and make sure patient is breathing. And R for reassurance, because that's really important. And I have noticed it in my own private practice that is the most important thing is to reassure the patient and the team, and vice versa. The team has to reassure you that they are ready to help you to control everything. And of course, T for taking vital signs. Now let's continue with presenting a case. This is an actual case, and cases like this has happened in my practice for practicing for the last 35 years, has happened many times, and is so often that my staff, they would know immediately when a patient is going to have this condition. So this 16-year-old patient presented, totally healthy patient, presented for removal of wisdom teeth. After administration of local anesthesia, his face becomes pale. He feels dizzy. He starts sweating, and he's cold all over his body. He says that he is nauseous. Then his body gets rigid, as if he has convulsion. Eyes twitching. His blood pressure drops. His heart rate slows. A few minutes later, he loses consciousness. You can't even feel his pulse. What is your diagnosis? Could it be allergic reaction, anaphylaxis, epinephrine reaction with heart palpitation, hyperventilation, asthmatic attack, hyperglycemia from not having breakfast, seizure, angina, cardiac arrest, stroke, or syncope? If your answer or your thought was syncope, you're right. Syncope, in fact, is the most common emergency in any dental practice or medical practice. Syncope is defined as sudden brief loss of consciousness, drop in blood pressure, and bradycardia via neurological mechanism including cerebral ischemia and hypoxia, caused by loss of vasomotor tone in the peripheral vessel and pulling of the blood to the periphery. Basically, the blood flow to the brain is reduced due to vasodilation of the vascular bed, leading to decreased cerebral perfusion. In a young patient, it is usually precipitated by a generalized progressive autonomic discharge secondary to anxiety, pain, heat, or humidity. The initial adrenergic response to stress is followed by an overwhelming cholinergic surge just prior to unconsciousness. However, for elderly patients, syncope in patients over 50 years of age may likely be secondary to cardiovascular disorder, for example, dysrhythmia or arrhythmia, postural hypotension, hypoglycemia, or cerebrovascular insufficiency. When we look at causes of syncope, vasovagal causes of syncope are stress, fear, and anxiety. Pain, exhaustion, heat, and humidity also could be other causes of syncope. Orthostatic hypotension, positional changes when the patients are sitting in your dental chair and then you have them stand up suddenly after a long procedure. They could have syncope and pass out. Volume depletion from blood loss, pulmonary embolism are amongst the other causes of syncope. Cardiac arrhythmias, myocardial infarction, stroke, and hypoglycemia are also amongst many other causes of syncope. As far as the signs of syncope, I like to divide them into two categories: adrenergic and cholinergic components. Just to remind you that most arteries and veins in the body are innervated by sympathetic adrenergic nerve, which releases norepinephrine as a neurotransmitter. Some blood vessels are innervated by parasympathetic cholinergic or sympathetic cholinergic nerve, both of which release acetylcholine as their primary neurotransmitter. Anyway, here are the body's response during a syncope. Adrenergic component of signs of syncope are anxiety, pallor, pupillary dilation, and palpitation of the heart. Cholinergic component of syncope are diaphoresis or perspiration, very commonly seen, always look at the patient and feel the forehead for sweating, nausea, salivation, bradycardia, hypotension, sudden brief loss of consciousness, and rarely also we can see seizure. One of the most important part in managing syncope is early recognition of signs of syncope. This is the most important step in managing syncope. Signs like patients being pale, heart start sweating, cold skin, as I said, being nauseous, bradycardia, hypotension may be noted very early on. But if you suspect the patient may develop syncope or has had past history of syncope, make sure to address the patient's stress first. I will sit next to the patient and start a conversation to distract them from their stress or anxiety of being in a dental office. I'll recline the chair, ask the patient to bend their knees, and preemptively place a nasal oxygen mask even if they didn't have syncope. As far as local anesthesia, I make sure to give adequate but not excessive amount of local anesthesia and talk to the patient as I'm giving the local anesthesia and observe any changes in their skin color or blood pressure changes or sweating. In other situations that the patient shows sign of syncope, I take the following steps with the help of my team. Check airway. Make sure there is nothing in the patient's mouth that he or she can aspirate. If the site is bleeding, I place a gauze pad that part of it is visible from outside of the patient's mouth. Start the nasal oxygen mask and deliver 4 to 7 liters per minute of oxygen. Place the patient in supine position as shown as soon as possible, except during if patient is pregnant, where you put the patient on their side. Check their patient's pulse. These days, getting a pulse oximetry is so inexpensive that you should have a pulse oximetry in your practice. Now, some people, they hold the leg up, have someone hold the patient's leg up. You don't need to do that. You need to elevate the patient's knees, as I demonstrated in that picture. I found this to be the most practical and effective way of returning the blood flow to the brain. Monitor the vital sign continuously. Reassure the patient, talk to them. Aromatic ammonia inhaler if was needed. Personally, I do not use ammonia inhaler and prefer to take all other steps as listed above. Remember that signs of recovery are that vital sign returns to baseline value, patient is alert. And signs of deterioration are when vital signs are unstable and mental status is labile. I like to finish this part of the lecture with a condition that most probably you have never heard of it. This 17-year-old patient came in and all her past medical history based on the documents that her mother completed and verbal questioning was basically normal on the day of the consult. But when she returned for the day of her procedure to remove 4 impacted wisdom teeth, after I started the IV, she casually said, "By the way, I have POTS," which my team and we thought that she said she used pot, smoked marijuana. As I continued with the usual doses of IV medication, and she was now being slightly sedated, we noticed that she looked pale, with cold sweat on her forehead. Her heart rate increased significantly, but her blood pressure dropped. We took all precaution as if she had syncope. Her vital signs became stable, although no more sedative medication given to her at this time. So I proceeded to complete the procedure, which was about 20 minutes, and all 4 impacted wisdom teeth were removed. When her mother came back, I asked her if there is any condition, disease, or syndrome that she had in her past history that we were not told about. Hearing the word syndrome, she now remembered that, oh yes, she has a POT syndrome. She woke up, went home with absolutely no issues afterward. But I was curious about POT syndrome, POT syndrome, postural or orthostatic tachycardia syndrome. It's a very rare syndrome. Under anesthesia, for example, this patient's heart rate increases by 30 points per minute. The cause of POTS is unknown. Episodes often begins after a pregnancy, major surgery, trauma, or a viral illness. Episodes may increase right before a menstrual period. Importantly, anxiety does not cause POTS. Symptoms are demonstrated in these pictures, including dizziness, sweating, fatigue. Patient may have shortness of breath and chest pain with heart palpitation. These patients are instructed to eat smaller meals and fewer carbohydrate, drink lots of fluid, avoid caffeine, avoid standing for a long period of time. But something that I wish would have been also advised to the patient. I wish that the physician also tell the patients to let you that and other doctors and dentists to know about it, so we would be prepared and we look for those signs and symptoms and prevent that from happening. As I was wrapping up this presentation, a patient presented today with the history of malignant neurocardiogenic syncope, an extreme form of vasovagal syncope commonly found in pediatric patients. Understanding and knowing about the existence of the extreme malignant vasovagal syncope is of paramount importance, particularly to pediatric dentists, pediatrician, and oral and maxillofacial surgeon. These patients would have all signs and symptoms of syncope, plus a period of asystole or flatline, which could be deadly. So my goal in discussing this very rare form of syncope is to raise awareness of the primarily pediatric conditions and provide with a basic framework to recognize and evaluate and manage patients within a dental setting of these conditions. I hope this additional information is helpful. Finally, remember this patient, a 79-year-old patient that presented for denture insertion on a Friday night, and all of the staff were gone. Impression were taken 6 months ago. This is an actual case. He had a pack of papers, none of which were his medical history or medication list. While sitting in the dental chair, he became unconscious, and the question that I asked, what did you think that he had? Unfortunately, he had a heart attack. So the dentist left the room to call for an ambulance. Patient fell from the dental chair, and then when the dentist returned, he found the patient on the floor with multiple facial injury. Of course, we repaired all of the facial injury in the hospital, and he recovered very well. But one important point is never leave a patient alone by themselves. So emergencies in dental practice could be prevented, and they could happen to anyone, patient, doctor, staff, bystander. About 10% of them are preventable. When you prepare for an emergency, as I said before, the emergencies cease to exist. So please remember that point. Now, let's summarize it all. 5-point plan to prevent emergencies. Document and update accurate and comprehensive patient's health history and records. Use careful routine patient assessment procedure. Implement the stress reduction procedure. Recognize early sign of emergency distress. Organize office team management plan for emergency preparedness. Once emergency happened, recognize that a problem exists and remain with the patient. Diagnose the problem correctly. Activate office emergency system and EMS immediately. Keep the patient alive until trained personnel arrives. Remain calm, act swiftly and definitively. Never administer drug without definitive indications for that medical emergency. Once the emergency medical services arrive, meet and escort EMS team to the office. assist with BLS, assist with ALS or PALS if trained, prepare emergency drugs for administration, monitor and record vital signs properly. Now, when medical emergencies happen, there is a medical legal aspect of medical emergencies. So you have to keep a written records of the following: time of onset, vital sign taken during the emergency, time, name, dose, and route of drug administration, effects of the drugs and treatment provided, time of initiation of CPR, the status of the patient at the time patient was transferred to EMS should be all recorded carefully, and on the day and the moment that after the emergency patient was taken to EMS. Ignorance is a major issue during a medical emergency. On February 2014, a 64-year-old female in Connecticut goes into cardiac arrest while having multiple teeth extracted and implants placed in. The practitioner ignored warning signs from the staff that something was wrong. Patient died from cardiac arrest. Criminal charges were filed a year later against the doctor. Medical errors can be defined as the failure of a planned action to be completed as intended, or the use of wrong plan to achieve an aim. Again, if you're prepared for emergency, perchance emergencies cease to happen. Benjamin Franklin said it the best. Think about it. Are you prepared? By failing to prepare, you are preparing to fail, as he said. So I hope you like these presentations, and I look forward to continue this conversation in the next presentation that I would discuss with you. I look forward to having you guys as my guest, and I hope you enjoyed this part of the presentation. Stay safe, and I look forward to talking to you very soon.